Welcome to Lesson 3, where we will be reviewing obsessive compulsive and other related disorders, which now has its very own category in the DSM-5. And our verse for this lesson again is Mark chapter 10, verse 27. Jesus looked at them and said, "With man this is impossible, but not with God. All things are possible with God." The experience of obsessive compulsive and related disorders are very common and growing in our culture, and many begin in childhood. We certainly have both the experience of an obsessive compulsive disorder as well as an obsessive compulsive personality disorder, and those are two different things, but they do often look similar. And so they do include the experience of obsessions, which are thoughts that are just stuck and repetitive, or compulsions. And these are behaviors or acts that one feels that they need to complete in order to reduce anxiety. They can be very time consuming. And it is important to look at the criteria for diagnosis because many individuals can have obsessive compulsive like characteristics or traits, but that doesn't mean they have an obsessive compulsive disorder. However, it's very common in today's society for someone just to be labeled as having OCD just because they might be fastidious or they like a clean environment. So we have to be careful about that because certainly OCD is a real disorder that can be very impairing for some. And it does cause quite a bit of distress or interference. And really, it's when it's causing that distress or interference in a person's life that it becomes a disorder. The cost of this disorder is relatively high, $8 billion a year in the US. So there is certainly a great financial burden here. And again, it can begin in childhood. We actually have 50 to 80% studies showing beginning in childhood or before the age of 18. And 60% of the individuals with OCD will continue to have some symptoms, though the symptoms may not be causing distress or interfering with their life. But they may still have some of those fastidious traits or um, compulsive behaviors. And again, it is relatively common. The lifetime epidemiology suggests anywhere from 1 to 3%, and at least a third to a half are estimated to have had symptoms before puberty. And different studies have different results for the experience of OCD, and so certainly that may be due to cultural norms or possibly genetic, but it's estimated at 0.7% in one US study and 0.25% in a UK study. There are two peaks or two periods where there's an increased incidence, and one is with the age of 7 to 12. And in 7 to 12-year-olds, we have males more frequently than females. In the other peak, age 21, we have females greater than males. And exactly what are obsessions? Well, they are anxiety provoking ideas, images, fears, thoughts, or worries. And one thing about these obsessions are that they are intrusive, they're interfering, they're unwanted. It's not that somebody just likes to dwell on these things or think about such things. They're experienced as unpleasant, uncomfortable, and distressing. So, somebody who is obsessed with something that they love, say a hobby, collecting things, and they love just spending time talking about it, thinking about it, having thoughts about it, would not necessarily be classified as an obsession unless the thoughts were intrusive, unwanted, unpleasant, uncomfortable, or distressing, interfering in some way. And what are compulsions? Well, they are considered repetitive behaviors or mental acts. They are done specifically to ignore, reduce, or eliminate anxiety or distress. And they're executed often according to some very specific rules. Compulsions without obsessions are more likely to occur in younger children. And rituals that include touching can be considered or confused with the experience of complex tics. So, complex tics are often confused with the experience of a compulsion. While there's no real consensus about how to best define the age of onset, some authors believe that the age is when the symptoms first began, and others define it as when the symptoms first started to interfere with normal functioning. And so we have a couple different classifications, one of early onset or occurring before the age of 10, and a later onset occurring um, around the age of 17 or later. And it's important to differentiate the onset because earlier onset um, does have a distinct pattern and it may be a specific subtype. It is postulated that the early onset type of OCD is one that may be more severe and may have a persistence of symptoms that are less responsive to treatment. In addition, there's usually less obsessions, more tic like compulsions or sensory phenomenon, and they may have a comorbid tic disorder as well. And those with early onset OCD may have a higher symptom severity in both aggressive obsessions or the experience of sexual or religious obsessions or compulsions. They also often have a focus on symmetry, ordering and arranging, um, both with obsessions and compulsions. And so patients with OCD may have symptoms in any one of these areas or even more than one. And those include contamination or cleaning, obsession or checking, symmetry or ordering, and hoarding. Hoarding now has its own separate diagnosis as well as one of the OCD related disorders. Certainly, I think we're all most familiar with the OCD symptom of hand washing or an individual with OCD having extreme fears of germs, and so they're constantly cleaning with disinfectant. Now, obsessions, a very common obsession is checking. And so that's the need to check over and over again whether the door is locked, whether the oven has been turned off, things like that. Symmetry or ordering often occurs in their environment, such as in their bathroom. They need to have the shampoo bottles and all the toiletries lined up in a certain way. And if they are changed by someone, maybe trying to help straighten or clean, that's very distressing. So they cannot have it out of this particular order. Mentioned hoarding disorder has its own specific diagnosis in the DSM-5. And this is another disorder that is casually thrown around, that perhaps somebody who has a little cluttered home or likes to collect things may be labeled as a hoarder. But people with hoarding disorder have rooms that are stacked full with items and hallways that are difficult to pass through because of the amount of clutter. And so hoarders typically will not invite guests over. And if somebody does come over, they would feel very uncomfortable. Symptoms of hoarding include being unable to discard possessions, feeling great anxiety over the very idea of throwing something away, and again, that limited living space in the home because of such collection and hoarding of objects. Floor and counter space is often covered, and the individual also often feel isolated and have some loneliness and depression, and have fear or embarrassment of having people in the home, so that they do become withdrawn, disorganized, and they are often indecisive about where to put things, as there often is no room. Comorbidities occur, and individuals with hoarding disorder often also have some depression, social phobia, generalized anxiety disorder, and ADHD. So they have that poor organizational skill. In addition to hoarding disorder, some other obsessive compulsive related disorders include body dysmorphic disorder, trichotillomania, and other impulse control disorders. And these all share the experience of intrusive thoughts, anxiety, and repetitive behaviors. There is, again, some nature and nurture here, in that there is a shared genetic mechanism that has been identified. Just like with adults, children with OCD often have some comorbidities as well. 60 to 80% will have one or more comorbid disorders, and the most common are tic disorders, attention deficit hyperactivity disorder, other anxiety disorders, as well as mood disorders or eating disorders. The association between OCD and tic disorders is the most striking, and children with OCD have reported rates of tics ranging from 20% upwards to 59%, whereas in adolescents or adults, it's only reported around 9 to 6%. Many tic disorders are transient, and children do tend to outgrow them, or they remit spontaneously. But 48% of early onset adult OCD patients do also have a tic disorder or Tourette syndrome, as compared to only 10% of those with a later onset. The course of OCD is heterogeneous, and the onset of symptoms can be abrupt or it can be insidious. And really, the type of experience or symptom varies considerably from patient to patient. Some may have more of an emphasis on compulsions, other the obsessions, and it's also frequent for these symptoms to change over time, even though they may have a consistent thematic uh, occurrence. So, just like with adults, there may be quite a bit of time with symptoms before the diagnosis is made and treatment begins. So studies report an average of 2.5 years from the onset of symptoms until finally getting a diagnosis. One of the reasons for this is secrecy. Patients are often very aware of the symptoms being abnormal, and so they feel ashamed or guilty about their symptoms and often try to conceal them until they get so um, increased that they interfere with their daily functioning. So, mild or moderate cases may only be diagnosed when things like um, academic failure begin because they're unable to complete the school tasks or constantly throwing away assignments because they're not perfect. Or they have rashes and severely chafed skin as a result of washing compulsions. And so assessment is very important with OCD, and it may be one of the most often forgotten screenings that is completed during a psychiatric evaluation. But it's so important to include screening with questions in this area, specifically because of the secrecy surrounding these OCD symptoms. And so here are some questions that can help. Questions towards parents of younger children and can be direct to an older child or adolescent. Has your child ever shown concerns about catching a disease after touching something or unduly worrying about dirt, leading to repetitive hand washing? Has your child ever shown a preoccupation with ordering and arranging things so much that it interferes with the normal life or schooling? Has your child ever shown a need for things to look, feel, or sound just right? Has the child ever shown excessive worries, fears, or concerns about aggressive sexual or religious thoughts? And has the child shown an excessive need to collect or hoard objects? And so, if the answer is yes to any of those items, it does not necessarily warrant a diagnosis of OCD, but like any screening tool, it does warrant further investigation and a more detailed assessment. So, after the screening questions, you may need to get information from a parent and teachers, and you want to engage the child in some type of a play activity or drawing and see if you can elicit the symptoms in vivo. Um, Certainly, we do always need to rule out the experience of this as normal ritualistic behavior of childhood. And so, look at the developmental age and stage of the child, as well as the role of the family. But again, if any of those screening questions are positive, you're going to want to go ahead and utilize one of the rating scales, um, such as the Child Yale Brown Obsessive Compulsive Scale and some of these others. The etiology of obsessive compulsive disorder is one that has some clear genetic heritability, and there have been some chromosomes that have been identified, and as well the association of a variation in glutamatergic expression. There may be some non genetic factors as well, such as emotional stress, traumatic brain injury, and then some associations that have been identified, such as excessive weight gain during gestation, birth injuries. Uh, Group AB hemolytic streptococcal infection is very common in pandas. is certainly the um, experience of a post-acute strep infection where OCD symptoms can occur. And again, we have some neuropsych deficits that are postulated, and as well alterations in serotonin and oxytocin balances, and familial accommodation. So, a wide range of risk factors. And so, in beginning treatment for OCD, it's important to first identify the worst or most impairing symptoms to target. And then try to identify how the family might be accommodating this behavior or maybe even reinforcing it in some way. You want to consider how long the symptom has been occurring, and as well look at family dynamics and any other comorbidities that the child may have. And treatment includes the combination of cognitive behavioral therapy, often with medication management. And here are some of the most commonly utilized fluoxetine, fluvoxamine or Luvox, paroxetine, sertraline, and clomipramine. Clomipramine being one of the tricyclic antidepressants. That one is most commonly used for trichotillomania or hair pulling. Um, and some of these medications are being used off label for children, which is a common occurrence. But again, you want to select a medication off label only when there is evidence supporting its efficacy, which we do have with these. Psychoeducation is important again because, again, it's important for the parents and the teachers to understand that the behaviors are not willful. And so, not to be punitive or punishing the child for continuing to maintain these various behaviors. And cognitive behavioral therapy is certainly one of the most commonly used approaches. And it's actually the only psychological therapy shown to be effective in the treatment of OCD. And so it probably is the best first line approach for mild to moderate cases, but does need a combination with pharmacotherapy for severe cases. And what we include with the CBT for treating this is some exposure, some response prevention, some cognitive restructuring. And again, we mentioned the use of antidepressants to assist or often used in conjunction with the CBT. It takes time, though. You can expect at least a minimum of 12 up to 25 sessions to have some improvement. And the best outcome is with family involvement. I often solicit the role of a parent as a coach in the CBT coach because the therapist is not at home. So, having with the child's permission and plan, the parent to be assisting with practicing some of the homework assignments in between sessions. Sorry, we actually have these slides out of order, so there is one more slide after the reference page. Psychoeducation is a very important component when dealing with obsessive compulsive disorder. It's important for family members to have an adequate understanding of the behavior, and so that they are not punitive and not feeling that the child or adolescent is being willful. And it can be very much a pattern of behaviors that can interfere with the family's functioning as well, with running late for various things. And there are a number of self-help books that do a very good job of explaining OCD and as well the therapeutic process. And there are a number of CBT manuals that can help to guide therapists and families through the process. It often takes a combination of medication and therapy together. Patients who are medication naive occasionally are resistant to medication and may try therapy alone. And if they are not making progress, definitely consider comorbidities. Is there a comorbidity going on that also needs treatment, or is medication needed as well? Medication alone also doesn't work very well at changing some of the behaviors. So, really, they go hand in hand for treatment of OCD. And there are support groups, and support groups can be very helpful because, again, it is a problem that does impact the whole family.